Welcome to As a Woman, Fertility, Hormones, and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of FFS-For Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and this podcast exists so that you can learn more about your body and your fertility. If you are new here, I'm a board-certified fertility doctor, and every single day I talk about your fertility, your body, your health, and your hormones. And I am always so surprised at what people do not know about their own health. Every single day, even patients who come to see me will so often say something that just takes me by surprise. Even recently, I had somebody come in and tell me something that they truly believed, that they read online, and in fact, it happened to be very, very false. So today, I'm going to be talking about some of these common fertility misconceptions or things that I wish you knew about your fertility and red flag, warning signs, buyer beware stories. So fertility myths, misconceptions, and things that you should know coming at you today. Some of these things come from questions that you ask, and you can get your questions answered by asking them either through the newsletter, on Instagram, or calling the As a Woman voicemail. Every week we send out a weekly newsletter. You can go to nataliecrawfordmd.com/newsletter to sign up. When you sign up, you get access to a couple freebies. So things like my Trying to Conceive Starter Guide, you'll get access just by signing up for the newsletter. That's nataliecrawfordmd.com/newsletter. You also can ask questions every Monday on Instagram at nataliecrawfordmd, or you can call the As a Woman voicemail. The voicemail line is 657-229-3672. Again, that is 657-229-3672. And your questions come from all of these places. So I love answering your questions. I love that you ask them. No matter how much education I give, I know that sometimes there are questions that are just so hard to find the answers for. So we're going to dive into all of those. A couple last housekeeping items. Number one, YouTube just hit over 200,000 subscribers. So if you have not checked out the YouTube content, it is bite-sized, very easy to consume, and I record it right here in my bedroom, not some fancy studio. So it's really a direct reflection of the questions you're asking. Number two, for huge thanks for all of you guys who are sharing the podcast or coming up to me or telling me how much it means to you. It's really so special. Even today, I was sitting with one of our new employees in Fora, and she told me she was just on a trip with somebody who told her that they listened to the podcast when she mentioned she was working at Fora. So I love it. Anyways, let's dive into some of these fertility myths, misconceptions, things you should know. Recently, I was seeing a patient and we were talking about her medical history. And something that came up was the idea that she knew she wanted to be pregnant in the future and wasn't sure what type of birth control to be on. And in fact, she stopped the birth control pill a couple years ago and then got an IUD so that it could leave her body faster since the pill lasted so long. And this is really surprising because the truth for your body is actually quite the opposite. So the birth control pill is a combination of a type of synthetic estrogen and a type of synthetic progesterone. So ethinyl estradiol and a type of progestin. Most birth control pills have very similar estrogen. They almost all have ethinyl estradiol in different doses and amounts, but they can have really different types of progesterone. So if you try a birth control pill and you don't like it, you might just not like that progesterone, and often we can change the pill and you might have a very different response. It's very important to know that. The pill's half-life is actually quite short, which means the amount of time where half the medication is out of your body. So for the combined birth control pill, what we classically think of as the pill, that time frame is about 24 hours. So in one day, half the medication's out of your body. In fact, birth control pills' half-life is so short that simply missing one pill might cause an escape ovulation and increase the risk of you getting pregnant. If you've ever heard of friends or people getting pregnant on the pill, this is why. And if you've ever done fertility treatments and maybe you were on the birth control pill but came in for a baseline and had an ovarian cyst, that is a sign that the pill did not suppress you. On the other hand, the progesterone in an IUD, if we talk about a typical progesterone IUD, is a longer acting form of medication. Now, the mechanism is very different. So yes, when you remove the IUD, you remove the progesterone source, but it's important to realize that when you have the IUD in place, this is a constant release of progesterone. And some of these IUDs last 5-7 years, and you have an even higher dose of progesterone in those earlier time periods. So for example, if you have Mirena, those first few years you have it, you're getting an even higher dose of progesterone than you will in the latter years. This constant high progesterone, this is not what your body would normally experience, can have longer lasting side effects than the birth control pills, and notably can cause thinning of the uterine lining. So if you have an IUD in place and you're having amenorrhea or no periods, you would actually want to stop that well before you would stop the birth control pill. So I recommend that you stop a progesterone IUD 6 months before you want to get pregnant so that you can give your body time to get your period back. Now, if you still have monthly periods on an IUD, that can happen. That progesterone dose often does not suppress ovulation. So even though it's enough to thin the lining and you might not have a period, you often are still ovulating. In some women, it's not enough to totally thin out the lining and you just have much lighter periods, but you might still be ovulating and having a regular cycle. If you have a regular cycle and you have bleeding, if it's normal, I'm much less concerned. If it's super duper light, I still recommend you get it out early. And if you have no period at all, which many people think is a great symptom or side effect of an IUD, when I had an IUD, I loved not having a period. But that means you need to give your body more time to allow those receptors inside the uterus to see some estrogen before you get pregnant. On the other hand, when you stop the birth control pill, you stop the birth control pill and you will start to ovulate right away. In fact, you'll start to grow an egg within just a few days. So it does not have a long half-life. I still recommend that people stop the pill about 3 months before they want to get pregnant, only because it does prevent ovulation. And not that it takes your body 3 months to get back to an ovulatory pattern, but you have to know what your ovulatory pattern is. And by definition, a pattern is more than one. So if you want to have regular cycles before you get pregnant, you've got to have some cycles first so that we can see what they are. While we're talking about different types of birth control, the mini pill or progesterone only pill has a very short half-life, like 12 hours. Missing just one pill or taking it a couple hours late can cause failure of contraception. So that one does not need a prolonged time period unless you're taking it constantly every single day and have not had a period in a long time. The absolute worst contraception, in my opinion, if you want to be pregnant anytime in the next 2 years, is the Depo-Provera shot. Depo-Provera shot is an intramuscular injection. That's what Depo means. And it's of Provera, a type of progesterone. So a intramuscular shot of progesterone at very high doses. And it is going to last in your body for at least 3 months at a high enough dose to prevent ovulation. Meaning in studies, in the population, everybody's having ovulation suppressed for at least 3 months with that high of a dose. But many people have ovulation suppressed for a longer time period. It's just not high enough to be counted as a contraceptive for the general public. In fact, the length of time you might have ovulation delayed after using a Depo-Provera shot could be up to 18 months. And I've seen people come in to see me because they're not having periods or ovulating, and they are just startled and upset when they find out that the truth is that it was due to that one Depo-Provera shot. So when you're planning your future, this is part of why we want to think about our fertility, not just in the moment we decide to get pregnant, because all of these different contraceptive choices actually make an impact on your current and your future health, and they should be considered when you're thinking about when you want to be pregnant. Okay, well, another patient that I have was seen and was talking to me and explaining their history. And in doing so, they told me that they had their AMH checked a couple years ago. And when their AMH checked, it was nice and above average for their age. And they were so relieved since this meant that they had above average fertility and nothing to worry about. And that is not what AMH does. Of course, having more eggs is better than having no eggs, but let's think about AMH for a minute. If you think about your ovary, so I like to imagine inside the ovary is a vault where all your eggs are found. At the start of 1 month, a group of eggs comes out of the vault. From that group, one is chosen to ovulate and the rest of them die. What's super interesting is that you have more eggs available in a given month when your AMH is higher, and you have fewer eggs available when your AMH is lower. So having a high AMH is a reflection of a lot of eggs outside the vault, telling us that there's a lot of eggs inside the vault. This does not at all correlate with your ability to get pregnant. In fact, having a low AMH has also not been correlated with infertility, nor has a high AMH been correlated with fertility. All it is telling us is that you're not out of eggs, which is, of course, a good thing. However, having eggs does not mean that they ovulate, that their quality is good, that your tubes are open, your uterus is normal, the sperm is fine, or that you have fertility. So getting an AMH test, and this is why a lot of people in the field might say that it's worthless, a waste of money, you shouldn't do it, and some organizations recommend against AMH testing. I am actually a huge fan of testing your AMH if you want children in the future, because it at least gives you some data that you have. And yes, a high level might be reassuring. It doesn't tell you you're going to be able to get pregnant. And at some point, if you're not trying, you're going to want to freeze eggs or embryos or start trying, because age determines egg quality, will trump egg count every single time. In fact, I recently had a patient who was over age 40 who had an AMH over 4, which is so high for her age. An average AMH would be about 1. So great, 4 times the AMH. And do you know what? She's been pregnant 4 times in 1 year and lost every single pregnancy because genetics trump AMH. And I think that it's important to realize that it's a helpful tool. If your AMH is low and you're younger, you certainly will get the opportunity, 1, to intervene sooner or to make decisions that are right for you, to at least explore, should you consider freezing your eggs or trying at a different timeline? And then, of course, what I always think is the most important thing is, why is your AMH low? I also have people tell me, well, my egg quality is bad because my AMH is low. And those two things may not be related. Those two things may also be related. We do not know unless we go look. A good example, smoking cigarettes will lower your AMH and will harm your egg quality. That's not a debatable fact. You can come at me all you want, but that's quite proven in medical literature. Smoking cigarettes impacts both egg count and quality. So can autoimmune disease and things like endometriosis. That can impact the number of eggs you have and their quality. So some of the factors that may cause you to have a lower egg count do in fact impact their quality. Others don't at all. Maybe you had an ovary removed or a cyst removed. Maybe you have fragile eggs and you have a genetic condition so that you're running out of eggs faster, but their quality is just fine. Or maybe you were born with a lower number of eggs and that's just what you're predispositioned to have. But thinking that an AMH blood test is guaranteeing or proving or showing that you have fertility is a false assessment of the test. It is still a helpful tool, but that's what it is. There is no test to tell us that you will be fertile. Okay, another one is that you don't have to listen to your doctor's recommendations about exercise and fertility treatments, and it's totally fine to exercise. This one I hear a lot, and I think I understand where it comes from, because so many doctors in our space either are just trying to control every variable, or they don't give patients the space to think that they can interpret what their body can or can't do. And so that they may just say, well, you can't exercise at all if you're going through fertility treatments. And if you've been through fertility treatments, you know how terrible that is and how terrible that sounds, because it can take a long time. Exercise can be a great way to stay healthy. It can be a great way to combat stress. And for somebody to just flat out say you can't do it can be really harmful. On the other hand, you absolutely do need to restrict certain activities. We had a patient who even had ovarian torsion riding the bike and being in the saddle position because ovaries are not always stable with that type of movement. So what I always tell patients is that when you're going through fertility treatment, what we're worried about is in fact ovarian torsion. Ovarian torsion is where the ovary twists upon itself. The ovaries are not tacked down in your pelvis. And when it twists, it constricts the blood vessels that provide the blood supply. This causes the ovary to undergo necrosis and it can start to die inside your body, and is one of the very few surgical emergencies that we do have in this field. Now, I tell patients this. I'm a big fan of exercise. If you've been around here, you know that. But imagine if you're going through any fertility treatments that your ovaries are like water balloons in your pelvis and they need to stay there. They should not move. So if you are even jogging or riding a Peloton bike, they may jiggle around and not be staying in your pelvis. Now, walking or lifting weights, especially if you're not jumping, those things are fine. Things like yoga, which might seem like it should be okay, can actually be very problematic if you're putting your body into an inversion, meaning putting your head down and your hips up, where the water balloons are coming out of your pelvis. So it's a myth that you can't exercise at all. It's also a myth that you don't need to listen to your doctor and that it's fine to exercise. So there should be restrictions when you're undergoing ovarian stimulation. And I think it's important for you to not just dismiss things that your doctors are saying. Another one is that if the sperm looks good on a semen analysis, it can't be a male factor. And that is not true. In fact, one thing that we will find is that sometimes couples will have unexplained infertility, which remember, unexplained just means undiagnosed. And when we go and we look on semen analysis, the sperm count and motility and shape look fine. We ovulate, the tubes are open, so we're not hitting any of the big factors causing our infertility. But when we go and do IVF, sometimes we notice a huge stop in development around the time the male genome kicks in. So if these embryos stop developing around day 3, which is considered a 6 to 8 cell stage, we know that development stopped when that male genome needed to kick on. And even though egg quality issues can present with a halt in the developmental process, seeing a huge drop just at that time period is highly concerning that there's a sperm factor as well. Most of these factors are in fact things that can cause fragmentation of the DNA inside the sperm's head, can cause inflammation. So when you're trying to make a difference, we can do expensive tests like a DNA sperm fragmentation that hasn't been shown to tell us anything except you should do IVF with ICSI, which is where you take a good sperm and put it inside an egg. However, I see male factor play a role even in the setting of ICSI. So I don't think that test is telling us that that's the treatment. And I think that you can get the same information from seeing your life and what you can do to decrease inflammation. So things like smoking cigarettes and marijuana, those are two of the highest things that I see that somebody doesn't admit to playing a huge role in what we see. Cigarettes, marijuana, tobacco, CBD, alcohol, high sugar diets, high processed food diets, not sleeping, having poor lifestyle, just overall. And some of these are by choice and some of them you can't help. I once had a patient who was a chef and he just sat at a grill, and you can think about where the testicles are. They're outside the body to be a little bit colder. And his, in fact, were not. So occupational hazard. But we can't discredit the impact and the importance of lifestyle factors and variables on sperm quality. Same thing goes for illness in men. Sperm are so fragile. So if you go and get the flu, I am expecting your sperm count to take a hit because your body was shifting its energy to take care of you. That doesn't mean you have to stop trying, but if you're paying $20,000 for IVF, this might be a time to really talk about and make sure your doctor knows if you just had some major illness or diagnosis. If you have diabetes, we see sperm really impacted by that. So the idea that male factor is not playing a part if the semen analysis is normal, or in the same vein, you had a kid before or a normal semen analysis before, so you don't need to do another one. Remember that sperm changes every 3 months. So absolutely recommend that if it's been a while, you're re-looking if you're struggling to get pregnant. Okay, another one is I was recently seeing a couple and they told me they just really thought they had this gut feeling that something was wrong because they were young, but they were told that they had to wait to see a fertility doctor until they had been trying 12 months, even though they actually had 12 months of unprotected sex where they were not trying but not preventing before they started what they considered trying, meaning tracking cycles and trying to time intercourse. And this is false in so many ways. So number one, if you are young, you have a high chance of getting pregnant per month. So people who are 30 and younger have a 20 to 25% chance of pregnancy per month. If you do the math, that means most people will be pregnant in 4 to 5 months, and that's a true statement. Over 70% of people will be pregnant within 6 months. And if you try for an additional 6 more months, only about 15% more will get pregnant at most. So 70% get pregnant the first 6 months, 15% more get pregnant the next 6 months. After that, a very small percentage get pregnant in that next year. You can ask for fertility evaluation at any time. You don't have to get a referral. You don't have to wait till your doctor tells you to do so. The recommendation is that if you've been trying for at least 12 months and you're not pregnant, you definitely should go see a fertility doctor. If you've been trying for 6 months and you're not pregnant and you're 35 and older, you should go see a fertility doctor. And if you're 40 and older, you should really consider seeing us before you start trying, or only try for a couple of months and then get an evaluation done. Remember that a fertility evaluation is a series of tests. We talk to you, we test things. Our average appointments are 60 minutes long. Your OBGYN probably has 15 minutes. So we're really able to dig into your history and see if there's anything that could be going on. When I see somebody young who's been trying for 6 or 7 months and they want to have a fertility appointment, we'll do all of our initial fertility testing. So we'll do an ultrasound and we'll do a tubal evaluation. We'll check blood work and a semen analysis. And if it's all normal, one of the options on our list is, hey, we could try a little bit longer. Since we've ruled out these issues, you could say, great, I feel reassured, nothing's wrong, I'm going to try a little bit longer. You might also say, well, we actually would rather advance care since the majority of people would already be pregnant by now, and that's fine. But one of the things that I hate the most, and I've seen it so often, is somebody being told they have to wait longer. If you're younger, I'm even more concerned if you're not pregnant at 6 months. If you're older, you shouldn't feel like you have to wait any amount of time. And patients who have been forced to wait, then find out they have no sperm on semen analysis, they have some obstruction, it is literally heartbreaking. Your tubes are blocked or there's no sperm, that you've been sitting there tracking cycles, trying for a year, and there was zero chance that it could happen. Similarly, if you don't have regular periods, you should not try any amount of time. You need to be worked up and try to get to the root cause. If you can't have intercourse because it's so painful, or your partner can't complete, either maintain erection or complete ejaculation, you're not trying fully. You need to go get an evaluation to see what could be going on. If you have known endometriosis or PCOS, or you had abdominal surgery, you've had pelvic inflammatory disease, an ovary removed, a cyst removed, a tube removed, those are signs that something else may be going on that puts you not in the quote unquote average population. And you should think about getting a workup before you start trying so that we can make sure we're not missing anything in your case. And then lastly, two I see all the time that are on both sides of the same coin. One is, well, it's okay that I'm not trying yet. I'll just wait and do IVF since IVF always works. IVF doesn't always work. And on the other end, I don't want to do IVF because IVF never works. IVF does work. Both of those things are false. IVF actually is quite successful if you have enough embryos. And that is a huge asterisk if. It is harder to find a genetically normal embryo as you get older. As we age, you start to have less eggs in the vault, less come out every month. When we do IVF, we can only get the eggs that are inside the vault to grow. So if you have less eggs, you're going to have less able to grow, less that we can get with IVF. As you get older and that egg quality drops, you're also going to have less eggs that are genetically normal. So a lower percentage of a lower number is less embryos. If I have an average 35-year-old and an average 40-year-old, the 40-year-old would have to do at least 3 times as many cycles as the 35-year-old to get the same number of embryos. And that's if everything's perfect, meaning month after month after month. If you are waiting to intervene with the idea that you'll just do IVF when the time comes, you might be making this entire journey much harder. That doesn't mean you have to get pregnant younger, but you're doing yourself a disservice by not getting an evaluation earlier, learning about your body, and getting the opportunity to do so. On the same or the other side of the coin, people who say, IVF never works, so I don't want to do it, it's a waste of money, that is just false. Most people who do IVF will get pregnant from it, especially if they are counseled appropriately and they're doing IVF in the right way. It is not a walk in the park. It is a marathon. Everybody's journey looks unique. You should not close off walls or barriers without learning about it. That's what we do, right? We get data and we make decisions based on the data. There's no right or wrong choice. You can make whatever choice you want. My job is not to talk you into something or to sell you something. My job is to give you an interpretation of the data so that you are educated and poised to make the choice that is right for you at the time when you're making it. And that choice will be different for all of us. But by closing off and not learning about an option, you are doing yourself a disservice. Learn about it, and then you can say, you know what, that's not right for me. But you can't do that if you don't even fully know what it is. Okay, well, to wrap up this episode, I'm going to answer a few of your fertility questions that you left on Instagram. So again, every Monday on Instagram at nataliecrawfordmd, we put up a question box and you can leave some of your fertility questions. Some of those questions will be answered right there on Instagram. Some of them will be answered here on the podcast and some in the weekly newsletter. Again, you can also call and leave a question on the As a Woman voicemail, which is 657-229-3672. Is letrozole supposed to shorten my cycle? I'm still having a long cycle and I have PCOS. So letrozole is a medication for ovulation induction and it's the first-line medication for PCOS. When we use letrozole, what it does is it eats up the estrogen in your body. Therefore, your brain senses this drop in estrogen and sends out a stronger signal of FSH. And that FSH signal should get an egg to grow. But remember, one of the problems with PCOS is that you have a lot of eggs and the FSH is getting diluted amongst all of them. Letrozole uses an indirect mechanism, so it's requiring the brain to interpret this estrogen drop and then sending out the amount of FSH it feels like is right. And there's different doses and different starting time periods. If you still have a really long cycle on letrozole, I'm concerned that dose isn't really getting the job done in the way we want it to, and personally, I would consider using a higher dose. This might be something where if you're at an office and they don't do ultrasound monitoring, which is really common in OB offices because they just don't have the infrastructure, that maybe seeing a fertility doctor who can do monitoring can be helpful to know what's really going on. What are your thoughts on home insemination for couples with erectile dysfunction? So any type of insemination, so IUI, intrauterine insemination, which can be done at home, but there's also some home kits that it's more like a diaphragm where the sperm goes in and you just place it really close to the cervix, can absolutely be beneficial if somebody has erectile dysfunction. One thing that I hate, capital letters, is when people turn towards insemination at home without getting a full workup because it's still costing you your most valuable commodity, which is not money but time. If you have erectile dysfunction, this can sometimes be a sign that you have low testosterone. As testosterone and sperm are made together, having low T might mean that you have low sperm. And this could mean that you might not even get pregnant with an insemination, or that your partner could utilize medications which could boost testosterone, not testosterone itself, medications like Clomid or HCG, but those medications might boost testosterone, boost sperm counts, improve the erectile dysfunction. So even though this can be a useful strategy, I always want to see couples get an evaluation first. Are you ovulating? Is your egg count normal? Are your fallopian tubes open and your uterus normal? And is the sperm count normal? And of course, I'm most concerned about a really low sperm count in this scenario. What are the tips for retrograde ejaculation, and can we still conceive naturally? Okay, this is an interesting one, and we'll end on this. Retrograde ejaculation is when in your body the sperm flows into the bladder instead of out of the penis. Remember that in men, they have the same connecting pathway, right? Both sperm and urine come out the urethra. And then think about a divided road at the end of it, one tube or one lane going to the bladder and one lane going to the testicles. Well, if sperm is flowing backwards into the bladder, you can diagnose this by often seeing no sperm in the ejaculate and then doing a urine sample and finding that there are sperm swimming in the urine. Well, of course, we want to get an underlying cause to see what's going on. Sometimes there's certain medications that can cause this, things like antidepressants or certain blood pressure medications. Substances like alcohol can often cause this based on how it might relax part of the bladder neck, the part that's supposed to prevent the sperm from coming in. There are some medications which you can try, which can cause sometimes the restriction of that bladder neck. Same type of medications people might use if they have urinary leakage might actually help prevent this, and that's often worth trying. So lifestyle changes, potentially these alpha adrenergic agents, but also we can use IVF, so we can get the sperm from the urine and we can isolate it and utilize that for IVF. So we still can use it even if these other options don't work. So naturally, maybe, maybe not, depends on if we respond to the medication and depending on if there's maybe a lifestyle change, if we stop alcohol use or a medication that is contributing, maybe we could be in a position to not have it anymore. So definitely something to talk to a doctor about and get a full evaluation. I hope you enjoyed learning a little bit about some of these fertility misconceptions and facts and myths that I talk about and see on a daily basis. As always, I appreciate you so much for being here. You can follow along on Instagram at nataliecrawfordmd. Don't forget you can ask your questions on Monday. You can sign up for the newsletter at nataliecrawfordmd.com/newsletter. And don't forget to go check out the YouTube channel. Consider being a subscriber and supporting us out over there. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.